I'm Dr. Nathaniel Chin, and you're listening to Dementia Matters, a podcast about Alzheimer's disease. Dementia Matters is a production of the Wisconsin Alzheimer's Disease Research Center. Our goal is to educate listeners on the latest news in Alzheimer's disease research and caregiver strategies. Thanks for joining us. Welcome back to Dementia Matters. Today I'm joined by Dr. Tomás León, a psychiatrist and researcher in the fields of old age psychiatry and dementia care at the Memory and Neuropsychiatry Clinic at the Hospital de Salvador in Santiago, Chile. He has participated in the pilot stages of Chile's National Dementia Plan, which launched in 2017. Dr. León is also an Atlantic Fellow for Equity in Brain Health with the Global Brain Health Institute, who recently has been working to channel his and others' experience with dementia to a younger audience through a medium they will understand and appreciate: children's books. Dr. León has published 4 children's books that explain 4 different forms of dementia: Alzheimer's disease, frontotemporal, Lewy body, and vascular disease, in an optimistic way so that children can understand what's happening to their older relatives who are experiencing it. These 4 books are available completely free online in both English and Spanish and will be linked in the show notes below. Dr. León, welcome to Dementia Matters.
Thank you. Thank you so much for the invitation. It's an honor for me to be here.
Well, to start, what led you to the field of dementia research and care? And in your answer, can you tell us, how did your journey as a psychiatrist and researcher begin?
Well, I think my journey started when I was little. As many people who work in old age dementia, I was raised mainly by grandmas. Both of my grandma raised me while my parents were working, so I had a very close relationship with her. And in that, my friends always told me that I was trained from the very beginning to hear and listen to old ladies and old men talk about their past and their stories. And then they started to get dementia. When I was growing up, I started med school and they started to get dementia. And I realized that despite having some knowledge about the brain and the process of dementia, it was very hard for me and for my family to care about this time. The first one was my mother's mother. Um, so I realized that one thing is having knowledge, about how the brain works and what part of the brains are the ones who are misfunctioning. But other thing is having your grandma or your grandpa screaming all day, or I don't know, don't want it to take a bath. So then I realized that those people need help. Like we needed help, and those people who are passing the same hysteria needed help. And then I started into psychiatry, more like neuropsychiatrist, because I was fascinated about how something that was very concrete as the brain, that we can touch it and measure it. Now we know we can't measure it as good as we want, but what is something that's tangible could impact in something that was so untangible, like the memory. I don't know, the how good or bad you behave. I don't know, your stories, your main personality. So this interaction between something that is organic and this is something that is not organic really fascinated me. So that was like the 2 ways that connect me to all its psychiatry and focusing on dementia. And it's funny because usually I consider myself someone who's really good at like taking care of problems, that want to solve problems. And the main issue with dementia and dementia care is that you don't really solve as much as we will want to. We mostly go with the carers and the patients in their journeys of dealing with dementia and living with dementia. So this has also been like a very like insightful journey for myself to learn there are some things that you cannot solve, but you can go together with the people suffering, and that is also very important. That is actually maybe even more important in these non-curable diseases that we have and that we will keep getting in the future.
Well, thank you for sharing that. Hearing that answer is so helpful, as I have read the story, the children's story on Alzheimer's disease, and I can hear your voice. in the children's book, in the idea of going in the journey and helping to explain that to someone so young who's seeing a loved one with the disease. Now, since in our research center in this podcast, it's based in the United States, and we're often discussing the state of dementia research and care here in the US, would you tell us a bit about the overall impact of dementia in Chile, where you are?
Well, Chile is as you may heard, it's a very long country. We are like, if you took the from the north of the south, we are like Europe, but we're very thin. And the cool thing and the interesting thing about that is like we're very diverse, either in our climate. For example, the north is like the driest desert in the world. The south we have like icebergs and like really Antarctic weather. But we're not only diverse in our climate, but we're also diverse in the population that we have. We have people who are ethnically diverse. We have people who are, I don't know, from the States or from the Europe ethnicity. And in that context, the impact of dementia is very diverse. We of course have a prevalence that has been going up as the rest of the world. We predict that we will triple that prevalence in 20 years, as probably most of the world also. But the thing is that we have a very varied type of care. We have a care that we also say like some part of our population is living in the, I don't know, the best Harvard level care that you can. Like you have people who are having PET scans, regular occupational therapy, paid caregivers, and once we probably, I don't know, if we ever approve aducanumab or lecanemab, we will be able, some people will be able to pay for that. But at the same time, I'm probably not that far, like 3 blocks that way from that person. We have people who are not have not money for pay caregivers, who have no money to even get, I don't know, antipsychotics or any medication, who have to quit their jobs to take care of their mother or their grandparents. So that's very interesting for us because it's a challenge that we have to at the same time be very like in the cutting edge of technology because we will have some patients that will require to give advice about, I don't know, how many pets can you do you have, how is it good or not to have lecanemab import from the States and be applied to them because they can pay it. But at the same time we say we should be able to provide care systems for people who have nothing. And that is a challenge that, as most of the countries, I think we could do better, of course. But I think we are trying to set a minimum of care. You know that okay, there are some people who will get excellent care, like and we will could discuss if that excellent care is really cost effective, and that is another discussion. But some people will get great care, but at least we will ensure that the minimum care available is very good. You know, is at least good. And the cool thing about that challenge is that dealing with that is not about having me like a really cool expert who's really good and like in a cutting edge researcher, but it's rather on having a lot of people who knows enough like in primary care, in like first care system of non-health professionals, non-medical professionals. um so my focus, and that's part of the why I read in the books, but why I also have written some training courses, online free training courses for everything, is like the problem of dementia is not going to be solved by having this really cool guy working 24/7, seeing patients like one after another. Because even that guy, if even if have like the solution of dementia is limited in the number of patients that he or she can see. But rather than say like, okay, I want to train like everyone I can, so ensure that the minimum care, the acceptable minimum care of dementia is available for anyone. I always joke and I say like when I'm old and poor because that's something that happened, and I go to any public hospital in my country, I want to be treated at least not with a haloperidol. Like at least they know that try to avoid antipsychotics in me if I have dementia and be agitated. Try to talk to me, try to be nice to me. That's my that's my goal.
Yeah, and that makes a lot of sense, though. There is this tipping point. Instead of having a small number of people who have all the knowledge, let's have a large number of people who have enough knowledge that we can reach the most number of people, provide the best care possible with that limited resource. And so, one of the things we face here, and I'm sure you face it too, is this idea of stigma and lack of education and trying to raise awareness of the difference between normal aging and dementia, and that these diseases exist. Are you facing that in Chile too, where you're having to explain that dementia is not a part of normal aging and there is this term dementia? Is that something that is prevalent in Chile too?
Totally, totally. It's something that I think we have to face many stigmas at the same time. That is very hard for us because one of the ones that we have to face is that one, the ageism, considering that most of the forgetting things or even, I don't know, mood disorders, sleep disorders, anxiety disorders are part of normal aging. Um, and we have to try to fight about that. But at the same time, we try to fight because we say, okay, let's do some tests, let's do some analysis, and they say, yeah, but I don't want to have dementia. It's not only that they normalize having some things that they forget, but also like there's a fear, and I think that was one of the reasons of this ages is fear that if they have something that is a disease, that disease could be very severe, could be very incurable as dementia, uh, and then they will have to take care of that. Like if you see something, you have to because you have to take care of that because you search for something and you find something. So we have that in the mostly in the medical field. I think that we say like, okay, if I don't know, some patient with 80-year-old patient has started to say that they are forgetful, you have to at least take a story, make some cognitive test. And the main answer for that is not like I don't know how to do that, because that's trainable. Is rather why? Why should I do that? Like not why in like in the but why in more like philosophical way. Like what's the point of doing that? Like because if I get the results and it's indeed dementia, mild cognitive impairment, whatever, uh, I have to do something, and that do something is starting. I have to tell the family, not the patient. We think that they should also tell the patient, but the family. And I am only gonna give them worries, and I'm not gonna give them solutions. So that's the main thing that we not the main thing, but one of the main things that we try to train the physician, the health professional is like, yeah, you will tell them that they have an incurable disease, and you have to do it first because it's your duty as like a health provider, but second because although that is incurable, as most of the diseases you are already treating, like diabetes, hypertension, and like all the 10 other diseases that they have, you have to do something. They have the right to receive at least a palm in the back. Like that's so rough for you. That is at least that's something, you know. Um, so we are trying to face that both in the population because they don't want to take tests or exams, and in the medical field. And it's that, and I think that second group is harder because they fit the first group. You know, they feed the population this nihilistic idea of nothing is ever done. So why care? So we are a group of like we are the ones who are in the wrong. We are the ones who is like this dudes, they're always bugging about their dementia, the cognitive tests. Why do you care about that? So one of the pain points that we have is to show them, and I say show the medical, the politicians, the policymakers, like this is important, not just in a moral way, because we could debate about that, but also in the economical, in health way. Like it's important to have a right diagnosis. It's important to have a correct treatment. When we go talk to the I don't know business administration, the hospital, we have to tell them this is cost effective for you to have a group of people telling people that they have dementia. And that is not easy, because the thing about dementia is that since it's a very progressive disease, they're still going to have cost and symptoms. So try to show them that it's important to take care of that, even though that is gonna keep happening. That's a very like everyday battle that we have to pay. To say like, yeah, this is gonna happen, but it's better to happen when you're informed, when you're well treated. That is happening if you're not informed. It's gonna happen worse. It's gonna happen more often if you scream back at them when they say that they forget about, I know they want to go home and they are on their own home. Like, trust me on that. It's gonna be worse than is now.
It feels like you need to write some other types of books directed at us as clinicians. But I do want to go into your children's books because they're so incredible. What inspired you to write them, and why did you write them for children compared to another age group? And then, is there a specific reason you chose the four different diseases that you did within dementia?
Well, I think that it's funny because the books has two main reasons. The first one is that usually when we do the diagnosis, we do something that is called diagnosis announcement, that we gather the family and the patient and say, okay, what you have is Alzheimer's disease. This is your brain. This is the, I don't know, the lesions. This is the result of your neuropsychology. And then we had in the hospital something that is called like we call it acompañamiento diagnóstico. It's like post-diagnostic care or support, that they have some sessions with this either psychology or social worker, and they explain the disease. Okay, this is the disease. This is what the doctor told you. That of course you just forget about everything because that's what happened after you go to the doctor. So let's repeat about that. Let's talk about brain health. Let's talk about behavioral symptoms. So they have a series of sessions about that. But I realized that one of the people that we never include in those sessions are the children's, because we are a hospital of adults people, and there's also an idea that children's, even adolescents, should not go to those hospitals, should not participate in this group because it's for adults. But the thing is that, at least in our cities and in our culture, and I think most of the cultures, many old people with dementia are living with their families and their grandchildren, and even if they're not living with them, they're seeing them like in the weekends, in the holidays, and the information that those children get is the information that we told the parents understood and give them to the child. And that is that, like the telephone game, that you say something that I tell that something to other people, and go on, and the end message is way different than the initial message. So I said, no, that's no good. And also, the first book in particular, this about Alzheimer, was the book that I will want to have when I was that child. They will say like, okay, this is what is happening to your grandma, because I remember my parents trying to tell me, like, yeah, well, the doctor told us something about their memory, about Alzheimer's, but we don't really know what Alzheimer is. We don't really know what is going to happen. So I remember asking my parents, like, why is she like that? Like, she's different. And she's like, yeah, but she's old. I don't know. She's always been meanie, so maybe she's now even meaner because I don't know, we fight with her. So the first one was my story. Well, it's not my story exactly, but it was based on my story. It's the book that I will want to. And when I did that, the first one about Alzheimer's, I realized that, yeah, but that was my story because my grandma has probably an Alzheimer's disease. But what about the people who has another grandmas or grandparents with other diseases? So let's, okay, what are the more frequent type of dementia that we saw? Okay, frontotemporal, Lewy body, and vascular dementia. Okay, let's do each about. So the third, like this, the second, the third, and the fourth book, I feel I'm a harsh critic to myself. I feel they're not as good. I love them, but I think they're not as good as the first one because the first one is closer to my heart, and because the other ones are created like purely fictional, based on my story with the patient and what I hear about them. But it's also like the story of children whose grandparents and grandmothers had other types of dementia. I will want to continue with other types of dementia, like I don't know, HIV dementia, post-trauma dementia, and stuff. But the number of people like dealing with that is scarce, and the money to read these books are not like infinite. But that's the reason. The main reason is that again to reach a population that we usually don't reach, to help kids that are probably having the same hard time that I had when my grandmothers had dementia. And also that, and this is more like a secondary outcome. There is a argument that you could say that if we teach those kids about brain health now, we could impact in the dementia prevalence, mental health issues prevalence in, I don't know, 20 to 40 years. I will, of course, not be alive to do that follow-up study, but that's the one of the points that we made have an impact.
I also think the additional impact is you're reinforcing important concepts for the parents because the parents are the ones reading these stories to their children and they might have questions too that are being answered in the books. And so I think you're sharing good information, trusted information that parents can actually, absorb, and it's about their own parent too, remember. So I think that's really nice. And as I was reading it, I was thinking to myself, these books they're not only important because they are explaining the different forms of dementia for children and arguably for the parents too, but they're telling these stories in the two languages, English and Spanish. And so I'm wondering, was that planned from the beginning to have it in two languages? And what was that process like? Did you write it in Spanish and then translate into English? And how did that go?
Yeah, they were written in Spanish, because that's my native language. And then when I published it in Spanish and made it available, so many people from other countries like, oh, we don't have anything like that. Especially in GBHI, in the Global Brain Health Institute, we have like this international network of people working with dementia. So many of them say like, oh, this is very great, but I don't know, I speak Deutsch. I am from Polynesia, so they speak like totally different language. And I said, okay, because my idea was always to give these books as a gift, like to, I don't know, society, to the universe, or whatever. So like, always gonna be like, these are for free. You can download it. If you want to, you can print it. You can, I don't know, publish in your social media. They're totally available for distribution for free. So, but I was realizing that the reaching was lacking because of the Spanish. So, okay, let's say I said like, okay, I don't know every language of the world, of course. So, but let's translate that in English, because it's probably easier to, I don't know, ChatGPT or anything like that, to translate it from English to your local language. So I start working on that. I have the help of a professor and a group of people who are studying translation. Helped me with Stephen Fry. That's the name. Stephen Fry helped me a lot with the translation. He was the professor of like translating as a Korea, and he helped me translating in English, because the thing is that you can translate it like by Google Translate, like word by word, but there are some things that are missing if you do that. Especially because I have in the book, the book about vascular dementia, I have a like local expression about what is an infarct in the brain. We call it a split. Like we call it derrame. That is like something that's split. Like if you split milk, and there's a joke about that. Not a joke, it's like an anecdote about that, because the kids thinks that they said, "No, your grandma has split," and she's like, "No, no, no, everything's gonna be wet in the floor when I went to the house." And like, "No, no, no, a brain split." And okay, a brain split, and they have a vascular damage. So we had to translate that joke, like this local expression, to English in an expression that could be then again culturally adapt to anyone. Because we cannot write the book again because the drawings were already done. So that the student fry helped me a lot with that. And the idea is that not only to have it in English, that's what the main point, but also to be able to other people from other countries to download the English version and translate about that. And like to our listener, like if anyone had the original PDF and to work with that in those programs that I'm not expert, but I don't know, Photoshop or whatever they use it to put the new work that, please send me an email to do that. Because that's the idea. Like if you can take the English version and translate it to your local language, and distribute that, they might be not culturally like exact to your population, but I think it's a very good first step. Like if you have nothing, this is very like best than nothing.
It sounds like such a process, for you to go through the writing, the different books, the translating. And so what was the most enjoyable part of this in creating these books? And then what was the most challenging part in doing it too?
I'm gonna start by the last one. I think the most challenging part was to translate like the medical knowledge to children's words, because I didn't want it to be inaccurate. I didn't want to say like, oh, there's a little man inside your brain that dies, and then the brain stop working. You remember that very old, maybe you're too young for that, very very old TV series that was about like some people inside your brain or inside your heart, and they took the brain to one place to another. I didn't want that. I was like, okay, this the cells, they're dying, this is what is happening, but at the same time I want to keep it in a language that they could understand. So I remember writing the first draft. It was not like a paper, but it was very close to a paper. Like this is the story of a grandma, 80-year-old old, no previous conditions, and they are facing ta 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 ta. So I have a lot of help from people who are child psychiatrists. I don't know, my wife, my relatives are like, no, no, this is not very good. This is not like acceptable or close to how a boy or a girl is speaking or is thinking. The editorial helped me a lot with that. But I think that was like the most difficult part, how to maintain the precision, but keep it simple. I remember that, for example, here we usually say that in Chile, I don't know why, we have the idea that we only have veins, not arteries. So, like in in the popular population. So, if you say like, "Oh, I have a vein that explodes in me, and I have an vascular infarct in the brain," so I had to put vein, and I was very like I said, like if my vascular teacher sees that, they say like, no, no, it's not a vein, it's an artery. The ones who broke in the infarct. They're like, okay, let me pass that. But I think the best part, I have two examples. The best part is like when people are saying like, I used your book with a patient. They really understand. It was very useful. I remember a person that I didn't know that I was a teacher. I said like, oh, you are the one. You are that guy who I get this because I have a student whose grandma has, I don't know, whatever, dementia, and I downloaded these books and was very helpful. And I was like, okay, this was meant. But I think the main like reward was, and you're gonna laugh because it was a time that we were trying to get my twins to sleep. Say like, what story you want to hear now? I don't know, Cinderella, or Riding Red Hood, or whatever. I want to hear the book that Daddy wrote about dementia, and I was like, oh my god. And, so that was, I would see that was like my peak moment. Like was like, oh yeah, of course I will read your book.
I can imagine that being I totally get that. I can imagine that being the best moment. So some parents and guardians who are listening, they might still say, "Okay, I have this book. I'm able to share this, but there's more information I want to express either to my friends or to my children, my grandchildren." And what tips or recommendations might you have for them in sharing complicated information? In being able to keep things accurate, like you said, but still be truthful in giving sensitive information to someone who's more, I don't wanna say fragile, but who at least, is younger and we wanna be protective of.
Yeah, I think that's very good subject. Like in dementia, but not just in dementia. Like any other really big issues that you have. I think the first advice I will give is that don't assume that your kids are stupid just because they're kids, because they're usually not. And having kids myself, I usually surprise myself when like, yeah, but that's what is happening, Dad. Like, don't BS us. Like, we know what is happening. And the second one is that I think it's better to have like a cruel, a tough talk once than having a lot of not as tough, sweetened talks a lot of times. Like I think in dementia and people who are having, I don't know, cancer, or heart diseases, or any other like severe disease, kids are gonna have questions. And usually the kids' questions are not the same ones that we have. I remember having my grandma. That one of the grandmas died early, and the other one dies a few months ago. And my kids get to know her. I remember that she has like severe dementia, like, and the question was not about like, so I read the book, like this is what a dementia is like, but their question was not about how, like, what is dementia, but rather like, is she suffering? Like, is she in pain? No, she's not in pain. Okay, that's good. Can I tell my name to her like every time that she asks? I was, yeah, you can. Oh, that's good because I didn't want to be rude. Like say like my name again because she asked me, I don't know, the week before, and she asked me now again. So I think that these books, I don't know, a movie or a cartoon that sometimes go about the subject, a hard subject, should be a starting point, not a finish point. Okay, if you read, for example, my books or any books to a child about dementia, cancer, or anything, it's not like, okay, this is all the information I'm gonna give you, but rather like, okay, this is something like this is happening to your grandma, grandpa, parent, sister, whatever. What question do you have? What worries you? And start from that. And if you don't know something, and this is, I'm gonna tell a short story after, uh, because we have something like that in the family. And some of the answer I don't have it because this is not my main area of expertise. Because I don't know. Because the doctors don't know. You can say that, like, we don't know. We are not sure how is this is gonna resolve or if it's gonna resolve at all. But we will be here with you. We will work together to get that information. And if we don't have that information, we will prepare for a scenario a scenario B. So also like be open to the question, be honest. Like if you don't know about that, like if I don't have no idea how your grandma is gonna involve with that. Um and be sure and ensure them that you will be there for them. Like we will be together. Like we will work that. I remember when my grandma finally died, and she like, is she going to the heaven because she was incinerated? And they were not sure how because they had the idea of people in tombs going to the heaven, not the people incinerated. Like how is she going to the heaven if she's not in a tomb? I said like, let's sit about that. Let's talk about that. Do you want to go to the if you're not, no, you don't want to. Okay, that's cool. Like, but let's walk your path together. I think that's the best advice I
Well,
can
I
give.
had a related question for you, but I feel like you answered it, but I'll still ask, you know, in this process of being able to translate this information and engage with children, how have you taken that and incorporated as a clinician and as a researcher and communicating to patients and research participants? And some of our listeners are researchers and clinicians, and but I feel like your recommendations for parents and grandparents can also apply to clinicians and researchers and how we communicate with patients and participants. Is there anything else you would recommend or any tips you would give clinicians and researchers who want to convey important information to their subjects?
Well, I think I have learned two things. I'm not saying I'm doing those two things like every day because that is it's harder to do it like in the practice, but I think I try to do it. Like, it's like It's like when you tell your patient they have to exercise and sleep well, and you're like at 3 a.m. looking papers in your phone. But I think at least my goal is to adapt what you have to say to their needs, not your needs. I remember that when someone has, I don't know, Alzheimer dementia, one of the most classical diagnoses that we get, in your head, you usually have like a YouTube video of people of things you want to say. Like, okay, you have Alzheimer dementia, and you put play in your mind, and it's like Alzheimer dementia is the most common type of dementia. The main causes are blah 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 blah. The main symptoms that you may have expertise da 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 da. So you're more like a YouTube video, like a pamphlet of the information you want to give. And the two bad things about that is the first thing is that up to 20-30% of that information is really getting into the patient. That's the first thing that I have learned. And like, they came to the second session. It's like, yeah, but what does my grandma have? Like, but I give you the speech. I remember giving you the speech, and the speech has, yeah, I remember the speech, yeah, but I didn't get it like at all. So, and the second one is like, I before I put my auto video of what is dementia, I usually say like, what are your concerns? What are you most worried about? Because I usually say then I have a speech, like I have something prepared for this. That is, I told every patient, but I want to know what's your concern. And I try to include, of course, that in my speech, like, okay, dementia, blah blah blah, and about what you asked about, I don't know if she's gonna forget about us. No, she's not gonna forget about you, like in the how the care that you have. They might forget your name, but she might not forget who you are, like being a significant person and whatever. Ah, okay, perfect. So I think that so be prepared to repeat and
No, those
adapt.
are great tips, Tomas. So, looking forward to the future, what are you working on next? And how do you hope the field of Alzheimer's and the related dementias research, the education, the care, it develops over the next 5 years, both in Chile and globally?
Well, out the last one, I think one of the issues that I see in the dementia research is like people are working more like in silos, that we have people working, I don't know, in biomarkers, and they're really good at creating biomarkers. And we have people working in, I don't know, public policies and people who are working on carers, but they're not working really together. They're working in parallel, but not together. So I of course will want to have biomarkers. Like I would love to have biomarkers. I would love to have anti-amyloid drugs. But at the same time, I realized that that is something for the future me, and the present me, and my present patients and families needs something that is not going to be answered by having a new biomarker. It might even be more complicated when they see in TB there is a biomarker that can predict Alzheimer for 20 years. Because they say like, oh, I want one, I want that. Yeah, but this is not really a good idea for you, cognitively healthy 40-year-old people, to have that in biomarker. Why not? But if the people who are doing the biomarker said it's great, yeah, it is great, but it's great for a small part of the population. I I I, I always tell this story that my mother is like my measure of the public, and they like probably once a year she texts me and say like, have you heard they discovered the cause of Alzheimer's? Or have you heard that they discovered the cure of Alzheimer's? So that's great for you. So I have to explain to him, like, yeah, it's not really the cure, it's a process. They're working on that. I think so. I think the research should go together with the current need. Like it's hard. It's a teacher once said, like we should be like a fish, one eye here, one eye in the future. So we should try to get together to be able to work at the same time. People who are working in like really hard science to understand what the interleukin X is doing with your brain, to the people who are in the first line. We should, we should try to understand that it's a continuum of care. It's not parallel, but rather togetherness. And in my personal future, we're trying to keep on training. That's one of my main project, to keep on working on training programs, try to reach as much people as possible. There are no new books in the future, but if I mean, there's always like an idea here, but it's not like in the very near future. What I will want to, and it's not directly dementia related, but rather disability related, because one of my kids has cerebral palsy, and of course it's very hard for her, for everyone. And as with dementia, I realized that the world is not prepared for her, for like, it's funny because you could say that she's not prepared for the world, but in reality, the world should be prepared for her, as should be prepared for people with dementia. So I think my next book, like, I'm not an author, but my next project in that area could be like that, like trying to increase the awareness of all disabilities. Because I know it's a process. Some disabilities, I don't know, here in Chile, for example, autism, or other, neurodivergent disabilities are more seen right now. But for example, motion disabilities, motor disabilities, age-related disabilities like dementia are less seen, and I think that's unfair. I think that we should be able to take care and adapt to everyone. For example, we have places here who are like low intensity sounds because of people without teams, but the same place doesn't have a ramp for my kids to get into. So I said, this is great, but this is also neat. It's great that you have some areas for people without teams. It's great, but you should also have a ramp for people with motor disabilities to get into your restaurant or whatever. So that's my next battle, to expand that we have at least advanced in dementia, that is not a lot, but it's something, and translated that into like all
Well, I look forward
disabilities.
to reading that book, whether it's a children's book or an adult book for the rest of the world to adapt. So, with that, Dr. Tomás León, thank you for being on Dementia Matters and spending time with us and answering our questions and sharing with us your experience and certainly the stories behind your 4 wonderful books.
Thank you so much. And I repeat my intention. Like, if any of our listeners have a question, want to connect, I don't know, have something that I could help, please send me an email. I'm happy to connect. I might not respond in the same day because life, but I will definitely get back in touch with anyone who needs some advice.
Well, you heard it here. Thank you. Thank you again, Tomás. Thank you for listening to Dementia Matters. Follow us on Apple Podcasts, Spotify, or wherever you listen. Or tell your smart speaker to play the Dementia Matters podcast. Please rate us on your favorite podcast app. It helps other people find our show and lets us know how we're doing. If you enjoy our show and want to support our work, consider making a gift to the Dementia Matters Fund through the UW Initiative to End Alzheimer's. All donations go toward outreach and production. Donate at the link in the description. Dementia Matters is brought to you by the Wisconsin Alzheimer's Disease Research Center at the University of Wisconsin-Madison. It receives funding from private, university, state, and national sources, including a grant from the National Institutes on Aging for Alzheimer's Disease Research. This episode of Dementia Matters was produced by Caitlin Rowerdink and edited by Alexia Spevacek. Our musical jingle is Cases to Rest by Blue Dot Sessions. To learn more about the Wisconsin Alzheimer's Disease Research Center, check out our website at adrc.wisc.edu. That's adrc.wisc.edu. And follow us on Facebook and Twitter. If you have any questions or comments, email us at dementiamatters@medicine.wisc.edu. Thanks for listening.